Hey there, guys. This is part two of Arterial Lines with Zach and Helen as my guest speaker. We are going to show you a little bit more when it comes to art lines because I didn't want to put it all in one video because it's too long, can't find things. So second video, we're going to show a little bit about extension tubing. So if you need to extend it out a little bit for a provider, we're going to talk a little bit about how to draw things from that safe set as well, just so that way if you need blood work, so you're not continuously poking the patient. And hopefully at the end of it, show you a few waveforms of what they would look like so you can understand what you're looking at. All right, Helen, take it away.
Hi. Okay, well, we're kind of trying to simulate this, so obviously my monitor's going crazy. But we're going to try and give you just like an example of what a waveform might look like and what you will see.
Okay.
So when doctor hooks up, like I said, it's a little cannula, it's an arterial line kit that he or she will use. It should be under sterile technique. Ideally, a timeout can be called, but depending if everything's crashing and burning and it's not a big worry. So I'm squeezing the bag right now just to try and stimulate some waveforms to try and stimulate a blood pressure. And that kind of looks pretty close as to what an arterial line waveform would look like.
So it's very rhythmic. It's like each time the heart beats, you get a...
What's really interesting, and this is just old lady observations through the years, is when you have a patient that's going through a sinus rhythm or AFib, and then they throw a PVC. So sometimes what you'll see is you'll see a nice waveform, then you'll see the same waveform of like a lower amplitude. So that'll give you a good reason to think, hey, is that PVC perfusing and producing a blood pressure? So like I said, an old lady trick that I've learned through the years, okay? So that's just your waveform. I'm gonna draw one a little bit later so you can see what it looks like and what the different parts of it are. It can get a little wonky looking when you have like atrial fib or something like that. Like I said, I'm just squeezing the bag just to produce an arterial line waveform. What you're really interested in for new people that are titrating compressors for the first time is that mean arterial pressure. Normally we try and hit 65, but that is going to be dependent on the patient. Somebody with bad congestive heart failure will live at a little bit lower of a mean arterial pressure as long as the mean stays okay. So my blood pressure right now is 115 over 13, but because I'm squeezing pretty good. So I'm getting a good systolic blood pressure, but my mean is only 46. So this patient might need some inotropic or some pressor support. All right, so that's where we are at this point, okay? And then you can correlate. All right, so let's talk about how to draw blood from an arterial line, because that is really important. And once you have a needle line in, if it's working right, you've got a golden shift, you've got an easy shift. If we try not to enter this as much as we need to, because it's just a sterile technique type of thing. But this is my patient, okay, so she's got this in her arm. And this reservoir that I talked about in the prior video is going to be very important because this is going to be our waste. Always, when I first looked at the ICU many moons ago, we would have a situation where we would draw a waste tube. All right, so we would take like a red top tube of blood, and we would and that would be our waste, and then we would draw our labs accordingly. This is normal saline. We used to put heparin in these bags, so hence when I was new in nursing, you might still see heparin in some things like the balloon pumps or something. We're not going to draw from there anyway. So, but this is our needleless our needleless port, and this needleless port this is what we're going to use. So please, no needles in there because you will have blood spurting back at you instead of going in the syringe. But this is our needleless. Port, and you can see it's not a needle. The needle is here. You're going to look on the inside of it. This gray coated. That's a needle in there for our tubes in and of themselves. This is what's actually going to interact with our port. So a needle mark should not be in there. All right, we're going to clean this with alcohol, okay, and 15 seconds, 20 seconds. And the next thing we're going to do is we're going to draw off our waste. When we would draw those red tubes, many moons ago, when we would draw those red tubes, 2 or 3 days later, after you draw enough waste, if you're drawing CBCs every 6 hours or lab work every 4 hours, the patient's hemoglobin is 5.2. And the answer is, did we do that? And the answer is, yes, we did, because we took off too much of a waste blood. We don't have to do that anymore. The apparatus that I used this morning in ICU doesn't have this safe set, so just be aware you may or may not see this. But like I said, this syringe-like apparatus, okay, is here, and I'm going to pull back on it. Typically, you can pull back at 1 milliliter per second. Okay, so we can pull back, and we're going to pull back, and about 6, 7, 8 cc's of blood. All right, and this whole tubing is going to turn red. Then I want to turn this. Okay, again, parallel is good, but if I don't want blood to seep in, blood that's been diluted with the saline, okay, with the saline that could mix with the bag, okay, I want to turn that. So now we're perpendicular. No blood can come into this. So exactly what I'm going to be getting is going to be here. All right, now I'm going to, like I said, I clean this off. Now I can put my safe set on here. I can go right in and start drawing my specimens. So you want to remember order of the draw. What I tell my Orients is to remember a mnemonic called Billy Goat's Roam Green Pastures. So blue is always going to be first, okay? So that's going to be our PT, PTT, gold, Rome, red, green, so that would be your troponins, and then green pastures, P, would be purple or pink. So I've got gold tubes, and I got a purple tube, and I got a pink tube here. Follow your beaker like the way you have to, okay? You know, for all that, it's just where you're going to be, the source is going to be the arterial source versus anything else. My gold, if I have these three things, my gold is going to be first, okay? So the order of the draw is really important. Here's the reason why PTs and PTTs and D-dimers and the blue tubes are first, because sometimes you have additives in other tubes, like the gold tubes or the green tubes, called citrate. Citrate could affect your PTT results. So think if you're titrating heparin or something like that, that would be very important. That's an important thing to keep in mind. You don't want to give too much or too little, just based on what it is. All right, so I'm just gonna, like I said, I'm gonna clean. Again, this can only go one way, and this is needleless, okay? And it's gonna go right into my port. And now take a look. I'm gonna puncture, and look at, I got fluid coming into my old tube. Once it stops, you're in good shape, okay? Invert it 4 or 5 times as necessary. Now I maybe have to get a CBC or platelets. I'm gonna do that, okay? All right. And away you go. And maybe I need to draw a type and screen. Okay, so I got the pink tube. But again, Billy Goat's Roam Green Pastures. All right, and notice how that stopped. Now I'm going to pull this off. Now I can take this off because I haven't punctured anything. I can clean it off. All right, now I have a whole tubing full of blood. All right, it's a little hard to envision, but what we're going to do is now we're going to go, we're perpendicular, we're going to go parallel, inject everything back in.
Now, when you were injecting it in or when you pulled it out, did you have to stop the stopcock on the actual patient?
You did not have to. You can leave that alone. Yep.
So everything is controlled from this one stopcock.
From that one reservoir. Yep. From that one syringe-like apparatus. I want to make sure that I click, okay, that you hear a click, and then that is secure. Otherwise, you'll have blood. Your blood's not going to clear. Then I'm just going to squeeze. I'm just going to flush accordingly. Flush till all my blood is gone. And if you really like it, a few extra cc's if you want. Yep. So once you see my tubing is clear, all right, and if I look and if I'm squeezing, notice when you're squeezing or messing with this, you've got just a flat line up on your arterial line waveform, but that'll all get situated once I quit messing with it. Okay, so there you go.
And once you do that, do you have to redo the phlebistotic access? Do you have to re-zero
if you've messed with it? Some people zero once a shift. I don't think so. I zero anytime I'm going to move the patient. You've got a hold in the ear that's on a ventilator with an arterial line, and you're going to be moving. You can never zero too many times.
So you don't have to if you're just messing with the blood.
But if I'm going to put her up, sometimes we'll have, like in the ICU, a carotid endoaortectomy, or maybe they want to get up in the chair and eat their breakfast. That's a surgery that they're pretty mobile the next day. You know, they're sitting up in the chair and stuff if everything goes well the next day. And maybe we have in an hour a lab to draw. So can I get up in the chair? Sure, you can get up in the chair. You have the orders to do so. They start eating and start using their right hand. You know, now I have to go in, okay, and maybe get, I want to check their blood pressure again. Then I would zero everything according to the plate-hemostatic X. So if you move your patient in any way, you always want it even with the armpit. So don't remember the fancy words. Armpit is the right way to remember it. That's the way I remember it.
And last question for
yes,
this
sir.
video, man. And once you're messing with it, so you're drawing blood, I saw you flushing it. Would you re-pump the bag up, or do you not worry about
I always look, yep, because at the start of my shift, I'm always going to look at to see maybe if this is 300. Can this lose a little moxie if it's standing there for a few hours? Sure, it can deflate a little bit of air. So you're checking that periodically through your shift. All right. So, yep, I can see I went down. Good observation that I went down a little bit, and I always want to make sure that I'm pumped up. Okay. So that's a periodic assessment. You know, sometimes if you're having a hard time, you should never see blood coming back up in here, squirting back, and it'll show that. So usually if that happens, most of the time your bag's deflated a little bit, and that'll fix your situation. All right. AR lines, just like IVs, can get positional. So if your patient's doing this, they're a little wiggle worm and they're doing that, that may cause your waveform to kind of disappear for a little while. I know, I heard you. Yes, I heard you. All right, cool. All right, so those just a couple things to keep in mind. Again, neurovascular checks, and then you can draw blood, but it's a very nice closed system. We can pump back into the patient, you know, the 6, 7, 8 cc's that we put out, and our patient's not losing blood every time that we do a draw. Right.
And I also heard something too. Listening to one of your lectures,
Uh-oh.
you had said that when it was in the arm for us EC people, sometimes sticking in the same spot for a period of time can actually change the waveform as well, right?
Well, what happens typically is if this has been in for a few days, you got a catheter. It's not really a needle that's in there, it's a catheter. And think about like your IV catheters. They're being whipped around with blood for a few days. They can get what they call dampened. So one thing that I like to talk about dampening, it's like, you know, we just had Noah in the Ark the last couple of days here. We've been raining like crazy. It's like you have an over dampened waveform. That's a sign probably we're losing a little bit of life there, and we may have to change it. Art lines, if a patient's pretty immobile, like our patients were paralyzed during COVID, at that time they lasted a little bit longer. But if patients are starting to wake up and get better, like in the intensive care unit, you know, it's a waveform, you know, that starts to get a little dampened. Okay, newsflash, it probably needs to come out. It should be easy also to draw blood. If you're starting to have trouble with drawing blood from it, and I was a recovery room nurse for many years, so I would take care of carotids. Sometimes if it wasn't put in right or something like that, we would have it wouldn't be able to it wouldn't be able to draw blood very easily. That's a carotid that's got to come. I'm sorry, an arterial line that's got to come out.
And also with IVs, we know that there's a certain amount of time that the lines can stay in. What would you recommend? I mean, in the ER we have a lot of overcrowding. If we have someone with our line, typically how long should they stay in for?
Typically they last about 3-4 days in the intensive care unit. And as patients start to get better, it's not like a clamsy or anything is attached to it, but the sooner you can get them out, the better, because it's an invasive line. I've had a patient where the stopcock, it was a different setup way back in the day, but the stopcock accidentally turned and it started leaking, and she had a puddle on her bed. I mean, she lost a gram of hemoglobin, so they are risky. If Usually within a day or two, hopefully they have figured out to stabilize you enough, maybe get you off pressors, or maybe even day 3 or 4, that can come out. So for the ER, you're probably going to hang on to them a little bit till we can get them over to intensive care. ICU really likes when they come with an art line because that makes it easier for us to draw blood and things like that. I would also recommend, one other thing I'm going to say is within an hour or 2, if you're going to get cultures, that probably would be the time to do it. I wouldn't use an art line 3-4 days old to draw blood cultures. You know, I probably would get that from a separate site. I know you guys are going through some blood culture education right now, so I probably would do the peripheral stuff.
Thank you so much.
You're welcome.
All right. If you have any other questions about this part of the lesson, please reach out, like, subscribe, comment. We will reach out. I'm going to help her get her own channel up so that way I can kind of piggyback on any kind of intensive care type issues. And I think that's going to be very helpful. If there's any other questions that you have, please don't hesitate.
March Madness skills.
All right. Bye, guys.
Bye.